So it has been quite a while since we've come together for one of these webinars. Time seems to go quickly, and at the same time, it seems like so much has happened. Since the last time we came together, we've all really, I think, advanced our practice and gotten more experience working with this medium. And we've been able to open up slightly. So we're seeing some of our clients and families now in person when it's helpful and needed. And we continue to offer virtual care. And it's really exciting to think about how we're thinking about this hybrid model as we go forward. We had this webinar scheduled early in the spring and we had to change the date for scheduling reasons, but this is such an important topic that we really wanted to get it to you. And today we're talking about how we support the safety of our clients and families, especially in this new virtual world. And I remember back in April, I was reading a New York Times article about a stark increase in rates of domestic violence globally since the start of the pandemic. And I remember being particularly struck and concerned about this in our own context at the time, and even now, given how many of our clients we were seeing in their homes, and many of which who are confined to being in their homes. We know there's lots of benefits to being able to reach clients where they are, and there's important safety considerations in doing so, particularly in the context of risks of domestic violence. So in this vein, it is my pleasure to welcome our esteemed panel today. As with our previous webinars, we're fortunate to be joined by some of our internal expertise from across the program. We have Dr. Catherine Stewart, who's a psychologist with Youth Forensic Services, Dr. Julie Werschler, who's a psychologist with Youth Forensic Services, and we will be joined, pending technology, because it will happen, by Kimberly McLean, who's a social worker with reproductive mental health. What's unique in this webinar, and I think we are especially privileged to be joined by one of our community partners, Maria McIntosh, who's the executive director of Bryony House, who I know has been doing so much work in this area and has such valuable expertise to share. So we're very, very privileged for that. So at this point, again, one quick reminder, we are recording for all of our listeners. Please type any questions in your chat box. If you're looking for the chat box, it's on the bottom right-hand side of your screen. If you click the chat button, you should be able to see what's coming up on the chat. And I'll hold those questions till the end and present them to the panelists. So on that note, I will turn it over to Dr. Stewart.
Thanks. So we're going to talk about opportunities and responsibilities for understanding and responding to risk of violence in the home with the transition to virtual care. So I work with the Youth Forensic Assessment Service, and so we're pretty used to considering risk of violence in many forms, but we also appreciate that before we start our work with our clients, we often don't really know the circumstances that they're facing, and so they could be at risk of violence themselves, or they could present a risk of violence to others. And so with the shift to virtual care, I think our concerns about risk of violence were really amplified. We knew that, like, at the time of the pandemic, families were experiencing a lot more stress. They were in closer proximity to each other and also to co-residents for folks living in a residential setting. There was a lot less access for external supports and safeguards that were typically in place. And so the risk of violence in the home was already escalated. And then we didn't want to exacerbate an already challenging situation. The nature of the work that we do, we often will ask about really sensitive topics that can be activating for our clients. And if they get dysregulated, we don't have the opportunity to follow them out of the therapy room as we typically would, or they don't have the travel time to de-escalate as they typically would, and their co-residents or their family members might be in the room next door. And so the possibility of some volatility, spilling over really quickly was quite apparent to us. We also knew that there's less privacy in the home setting, and so the chances of sensitive information being overheard and that being activating either to the client or to a family member was a real possibility. And then we also recognized that being in the home environment, although virtually, we may see and hear things that we wouldn't typically in a usual therapy setting. And so we wanted to make sure that we were taking these things into consideration in our work. And when we were asked about joining this presentation today, I think we wanted to participate because we knew that many of you across mental health and addictions see the same clients that we see, and also that you work with other clients that have issues with disruptive behaviors, conflict in the home, experiences or histories of abuse and trauma. And so we thought some of the things that we were considering with the shift to virtual care may be relevant to your work, even though the focus of your work is different from ours. So what we did is can you go to the next slide, please? Thank you. So what we did is we developed a safety screening tool. And I just want to talk a little bit about kind of the goal in developing that tool. We really just wanted to add to the safety measures that were already in place in the virtual care guide. And we wanted to not just identify different potential concerns with violence in different forms, but we also wanted to think about how to proceed safely, what risks would be manageable within virtual care, and in what situations might we need an alternative form of service. And I think one of the things that was really striking for us was recognizing that there was a real cost to not proceeding with our clinical work in spite of these risks. And so it really called for us to be creative about how to proceed with limitations. Can we identify a piece of work that's beneficial but less activating, those kinds of things. I want to emphasize that these decisions aren't easy, they're ambiguous. You know, we start that screening in our first session, but that evaluation is really ongoing. And so these were the things that we were kind of hoping to accomplish with the tool. And I'll turn it over to Julie Ruschler, and she can share some of the specifics of the tool with you. Thanks.
All right, thank you, Kathy. So for those of you who haven't had a chance to see it, this was a tool that we developed for forensic assessments, but it's been embedded in the revised virtual visit guide. So all of you would have access to this across the program. And so I'm going to talk about some more kind of universal things that are good for anyone to consider, and then this would be a more detailed guide if there are specific concerns that you need to follow up on. So that's just a resource that you can refer back to, because we know this can be like an overwhelming and stressful thing to have to evaluate. So on the next slide, we have some universal screening considerations. So, you know, in preparation, if you're going to be seeing someone virtually, and we know that now there's more opportunities to have initial meetings in person, which gives you a little bit different dynamic to assess some of this. But if you are seeing someone virtually for the first time, you know, reviewing the available information that you have and looking for any kind of red flags about kind of violence, either from the youth or within the family environment, and reviewing the safety considerations in the virtual visit guide. And it's really helpful to get multiple perspectives on this, you know, the youth, the caregiver, if there are collateral sources involved, because they may have different impressions of where the risks might be. And part of the reason why, you know, we want to lay eyes on clients either on Zoom or in person during the initial meeting is because this makes this evaluation a little bit easier. And, you know, I always say up front, like, because we're doing things virtually, it's a little bit different. I ask these questions to everyone, just, you know, trying to get a sense of what's going on for you and your family so that they don't think they're being kind of singled out. And, you know, really ensuring if there's a private place to be able to answer these questions, and just offering a yes or no answer, so that if someone is overhearing, they're not putting themselves at that risk. And recognizing that, you know, it may take a while if there are a lot of concerns, and it may take your kind of initial appointment to go through some of this. And so, you know, budgeting time in for that. And the next slide just has some examples of, you know, ways that you could frame this, you know, letting people know that we may be asking about sensitive or difficult topics that may kind of cause upset or stress, you know, asking about different concerns for themselves or others. So you obviously don't need to do all this, but just some examples. And then if through your universal screening, you are kind of flagging some potential concerns, then you would move to a more detailed assessment, which is where that guide as the appendix would really help you with a lot of kind of detailed questions to ask. Knowing about the history of violence or aggression will really help you with your decision making. You know, is the aggression typically with specific triggers, and are those likely to be triggered during the assessment? Is there kind of maybe more of a history, but not so much more recently? And who is at risk of that aggression? And one of the things that's become particularly apparent during the transition to virtual care is, you know, access to weapons in the home. And this is something that, if you're doing a suicide risk assessment, you may ask about means, but it's not something that we would often, typically consider, especially firearms and whether those are accessible to youth and if there's safety in place to help restrict access there. And then, some more kind of planning about, are there coping strategies that the youth and family can use if there's concerns or the youth becomes dysregulated, and do they feel comfortable with using that? Because some families may feel like they don't have the skills to control the child if they become upset. Others may have been working on that for longer and may feel more comfortable. So getting answers to these questions will really help with the decision-making process. And, safety planning, we often think about it for suicide risk, but, it's really helpful with risk of violence as well. Even if there's not really a lot of concerns, kind of flagging a few coping strategies that can be used if things are becoming a bit distressing or upsetting. Getting ideas from the youth and caregiver. Are there things that they're comfortable doing, but other things that they're not? And, how can we structure that? Can we, do in-person sessions for certain topics, but do some of it at home? Can that be managed with breaks or having a support person available? And you can use the safety planning document that's available to make a more specific plan and outline coping strategies and supports that could be available. And one of the things that it's important to consider, for your time management, if you're booked back to back with Zoom appointments, is it's, a lot harder to leave someone on Zoom who may be experiencing some upset. You really need to have that time to help with regulation, especially if you've been talking about more sensitive or distressing topics, and make sure that maybe there's someone available to support them once you're off the session, and a backup plan if you can't regulate them. So there's a lot of factors to consider. And so, decisions, they're going to be ambiguous. There's no kind of clear right or wrong answer in a lot of cases. Like Kathy mentioned, a lot of time, like there's a reason that the families are seeking services, and receiving that is going to be, really important. But you also, don't want to exacerbate stress or difficulties in the home. So really making an individual decision based on the family, and recognizing, that reevaluating that will be important because it may change over time. And, using your clinical judgment and consulting with your team, with your, clinical lead, with your colleagues about what the best way to proceed is, and what options are available in the care path for in-person versus virtual, and what's the best fit at that time, or for different pieces of work. And making sure that, checking in at each session, whether there's any change in the youth's level of stress or coping. Maybe things were going really well last week, but then, when you get on your session with them this week, there's just been a major kind of conflict in the home. So the situation is very different. So making sure that it's that ongoing assessment, and that you're, weighing the pros and cons. And so kind of, that's our description. And you refer to the virtual care guide and the appendix for more specific information and ideas.
Thanks so much, Julie. So next we'll move on to Kim. Kim gets the Perseverance Award for today, and the Timing Award. You arrived at like the exact moment. It's like somehow WebEx knew that it was time. So welcome. You'll just have to unmute yourself.
So sliding in, yeah.
Perfect. Thanks. Go ahead.
All right. So I'm from reproductive mental health. Actually, I'm a little bit on two programs now. I'm transitioning over to the forensics team. So the Reproductive Mental Health Program is a shared service between the IWK and the old Capital District Health Authority, which is now, of course, has expanded to the old CDHA to NSHA. And we are a assessment, treatment, initiation, and management service for pregnant and postpartum women, 19 years of age or older. And the majority of the women that we see have moderate to severe psychiatric symptoms with a significant impairment to their day-to-day functioning. And of course, we always worry about mom's mental health and the impact that that may have on attachment with little babies. And the moms typically are one of two types. We either have moms with a previous condition of mental health that a lot of times will become worse in pregnancy, especially if they've been stabilized on a medication and then choose to come off that medication or are required to come off because of safety. And the same thing with other patients where maybe they're breastfeeding in the postpartum, and same thing, they either choose to come off their medication or the medication isn't safe to have with baby. The other group are those that we previously maybe never were identified as having mental health, but then developed something. And the one that's on everybody's hot list is postpartum depression. But that's a bit of a misnomer because it can start in pregnancy and it can actually be a lot more than just depression. There can be anxiety, there can be a combination of the two, there can be bipolar that can develop. So we refer to them more as maternal or perinatal mood disorders. We are not an emergency service. We do triage based on clinical urgency, which is determined on the information that we're provided at the time of referral, as well as looking at a patient's chart. We do have limitations. We're not able to follow patients beyond a year postpartum. That's something from the Department of Health. So we do, of course, a lot of times our moms are especially anxious about going back to work in the year, at the end of the year. And again, we're 19 years of age and over. We also don't do loss or grief or bereavement, or any type of situation where mom is going to be parenting baby. So sometimes when child protection is removed, the baby from home. And part of that is because it can be a very crisis driven when patients are coming in, understandably so. And the other, it would, seem kind of cruel to have somebody sit in a waiting room with pregnant women or women with babies if they just had a loss. So from a trauma-informed care approach, it's not a good fit. Plus, there are other services here at the IWK that specialize in that. So that's kind of an overview of our service. One of the things that we know with pregnancy and domestic violence or intimate partner violence is a lot of times during a pregnancy, either the abuse can escalate. So some abuse that maybe was previously more in the emotional or psychological range can then become physical. The abuse that maybe was physical pre-pregnancy can often escalate and become more severe. And a lot of research has indicated that when the abusive partner does physically assault the pregnant partner, it tends to be somewhere within that trunk area. So it's in that area where baby can be, so in the abdomen area. Fetal outcomes or fatal outcomes, a lot of times in intimate partner violence during pregnancy, unfortunately, we do have homicides. And there can also be suicides that can occur. Non-fatal negative health behaviors can include alcohol and substance abuse, smoking, delayed or non-existent prenatal care. So sometimes we've had moms here where they've not had prenatal care for until they actually, there was a couple that we actually had that didn't come in for care until they were actually in labor. And from a reproductive health perspective, we're concerned about low birth weight. We're concerned about preterm labor and preterm delivery, insufficient weight gain, so that intrauterine growth restrictions that can happen, some of those obstetric complications that can occur, especially if there's any type of an injury, STIs, HIV, miscarriage, and also unsafe abortion. Sometimes women, when they are in that type of relationship and they do become pregnant, There's a whole area of intimate partner violence that focuses on reproductive coercion. And that's, in a nutshell, it's basically when the abusive partner controls the other partner's reproductive choices. So sometimes they'll tamper with birth control. So there was a mom I worked with where her partner constantly flushed her birth control down the toilet, or would refuse to wear a condom. So sometimes those moms will want to terminate the pregnancy. So choices and options with that sometimes are limited. So again, that's another outcome that we are concerned about. Physical and mental health, of course, injury is always paramount. Physical impairment that can occur, especially when there is injuries. Physical symptoms. So again, a lot of times when I worked in the area of domestic violence and worked at a shelter, it was quite unusual. I think in the decade or so that I was there, we did not have a woman admitted that was on some type of a psychiatric or some type of a medication of either anti-anxiety medication or antidepressant. So a lot of times there are some of those mental health symptoms that we'll see in conjunction with that. So the depression and anxiety. And there can be, of course, those difficulties or lack of attachment to baby. And then the effects, of course, of all of that on the child. And then as that child grows and is subjected to witnessing domestic violence, sometimes the partners will target the children as well. And we know pregnancy is a very vulnerable time for women anyway. So when that underlying intimate partner violence is there, it makes that even all the more sensitive for mom to actually reach out. So some research that I was involved in that was really interesting, and it was a great opportunity. It was a retrospective that we did where the shelter that I was working in, we had a grant that we had reached and achieved, and we had 25 years of data at that point that we could look at. And out of all of the data, and some of the things that were collected were the age when somebody had their first relationship that would be considered unhealthy or that would be considered abusive. And the large population showed that that happened in junior high school. So a lot of these women that were ending up in the shelter at a later age actually identified that their first relationship started in junior high. So we got a second part to that grant, and I was actually involved in going out into the junior high schools here in HRM and doing some presentations and some work around healthy relationships and what that looks like. And it's interesting because a lot of the youth that I worked with when we were doing that, they equated love to things like jealousy, or they equated the love to, how much control the partner had over them. So rather than seeing it as, he's trying to control me, he's trying to control who I'm seeing. And I say he because primarily that's been my experience. It's been a male, that's been the abusive partner. So they would identify that, well, that's because he really, really loves me, and trying to change what that looks like and what love actually means. And again, some of these kids also disclosed that, they were growing up in a home where there was definitely intimate partner violence there. So the idea that the age that we should be targeting kids and the from an education perspective, I think, is during that adolescent stage. Again, because once that kind of gets entrenched, it's a lot harder to get out of that abusive relationship. So universal screening, it's one of the things that we do at Reproductive Mental Health. So there's documentation. There is a document that's on our charts for assessing. It's listed as an assessment, but it's actually not an assessment tool. It's a screening tool for domestic violence, and it was here at the IWK. That's all currently under change. The policy is being revamped, and we're going to be revamping the document. So basically, the document on the front gives a list of tick boxes that you can kind of go through to assess risk. And then on the back, there's actually a figure, and you can document or note any changes or any injuries that you see on mom when she's there. The challenges, I'm sure that everybody's already kind of identified those around the challenges with COVID, where we're not necessarily seeing patients in our offices. They are being seen virtually. Partners can be present. Children are often present in the home as well, especially when school wasn't going back in. So again, that consideration for the environment for mom and working with her. And some of that is kind of thinking of outside of the box and being creative. So instead of asking questions, and a lot of times the questions, it's more in the way we ask versus what we ask. So, you know, saying to a mom, well, he doesn't hit you, does he? Right? Like mom most likely is going to say, well, no, he doesn't hit me. So some of the things that I may ask my patients are, so, you know, how does he feel? How does your partner feel about being a parent? How do you guys settle disagreements? You know, do you guys disagree a lot about how baby's going to be raised or things that you want to do with baby? And some of those things might give a little nugget or might give a little bit of a flag that maybe their relationship isn't such a healthy relationship or their communication isn't as great. So just trying to kind of think of different ways of asking the same question instead of blurting out, especially if it's a short, quick appointment that you may have for an assessment. You don't really have that ability to have a lot of rapport in that short time, and then that can be something you can come back on. Sometimes with moms or women that I've known that I've worked with ahead of time, and we've identified that there is intimate partner violence. We've developed a code word, and that would be even before COVID. So if, for example, in a session I'm doing with a mom, if she says to me, yeah, I was really craving pizza the other night, like pizza's our code word. So then I would know partners there, don't get into talking about the violence, there has been an incident, something's going on. So just a way of kind of, again, thinking outside of the box and being a bit creative with that. And then when risk is known, the things that we, are in place to do, we are under obligation to report to Department of Community Services if we are aware that there is abuse in the home where a child is at risk, imminent risk and harm, but then also mom safety. And sometimes it's planting that seed. You may be the first person that she's disclosed this to. She may not be in a position that she's able to leave at that point in time, but even letting her know what resources are there, letting her know that this is what she could be doing. Again, maybe developing that safety plan with her so that she's aware that if she does have to leave in a quick timeline, she knows she's got all of her stuff there and it's ready to go. So just ways of kind of preventing as much as you can losing that patient, I guess, for lack of a better term, not pushing. Because again, it's an extremely difficult situation to, especially for a new mom to leave that situation. And underneath it all, they do love their partners. Their partners, sometimes do, in their eyes, have redeeming qualities and things like that. And they do hope that the partner's going to change. And so it's working within those limitations too. And recognizing that risk may increase when she is pregnant or in that postpartum period. And that may also change to baby. So get involved. That's kind of my motto with everything, especially when it comes to domestic violence. Everybody needs to be involved because it affects everybody. It's not just the people behind the closed doors. It's communities. It's the school teacher. It's the kids in the school. It's your coworker. It's everybody. And the hospital does have a women in abuse committee. It's a very small committee, so it's always looking for people. And if you want to be involved in policy, you want to be involved in getting this new assessment and screening tool up on happening, then by all means. The other part of the committee was around doing some education. So even doing that policy again with the abuse committee. Women in Abuse Committee, we've redesigned the policy. It was severely outdated. And our hope and goal is that it's going to be a clinic-wide or hospital-wide, instead of just being on the women and children's side, that this needs to kind of be IWK-wide, especially when we look at the trauma-informed care approach as well. So there will be a new tool that will be developed after the policy's in place. and it will be more of a screening tool and more of an assessment tool, sorry, as opposed to a screening tool. And then, of course, the education of staff around how to administer that and, how to ask those questions, what to do with that information when mom or your patient does disclose that there's something going on, and to do it in a way that's supportive and to do it in a way that is not, that is trauma responsive, not just trauma informed, but trauma responsive as well. Because a lot of times people can kind of struggle with that piece of it. It's like, oh, I got the information now. What do I do with it? And again, it's working with her and finding out what she's comfortable with doing at that point as well. Because again, you could be the first person that she's told.
Thank you so much, Kim. Really appreciate it. I think it's beautiful again to see sort of how we're going across the program and how each area is learning from each other. So thank you for that. It's also a great segue. I think we've talked a lot about some of the things that we're doing internally, and I think as much as we work with our community partners and thinking about resources in the community, we're very happy today to have Maria with us. So Maria, I'll turn it over to you.
I think I'm unmuted now. Everybody can hear me? Okay. I'll thank Kim. You've helped me out. So I'm happy to be here today. I'm happy to hear all of the things that are happening. And I think my approach is to talk a bit about what Bryony House does, what we offer, some tips for consideration with respect to working virtually with clients. And then it's helpful, I think, to maybe offer some discussion, just if people have questions, to learn from one another, because there's certainly been a lot talked about today. So Bryony House is the largest shelter in Nova Scotia. We operate in HRM and surrounding areas. We offer a 24/7 distress line, so clients can call us at any time of day in distress, and we can either safety plan with them, support them, or we can bring them to safety by providing shelter, which is a really amazing resource. We are very direct service based. We have a daily program for children and youth within the shelter format. So they are supported by our children's counselors. We also offer housing supports to help women manage what their next steps look like, what's going to happen, how am I going to find housing. Inevitably, when you leave a situation of intimate partner abuse or intimate partner violence, you need a new home. You need to start over. So we have those components in place for our clients. We also have an outreach program, and typically women leaving the shelter will go into the outreach program, and we can work with clients up to a 3-year period. Through our outreach program, we also offer group programming. So we offer things like the LIFE program, which is a healthy relationships, personal skills program over 10 weeks. We can do one-on-one sessions. We can, help support the family moving forward, depending on whatever those pieces look like for the client and what their plan is. Certainly not everyone plans to leave. Sometimes there's reunification. So sometimes it's our involvement over a period of time in supporting that process if dad is getting some supports or the partner is getting some supports. So that's a really important thing to understand about how we work. In addition to that, we help with court visits. We help with supporting people going to custody appointments. We help people working with police. Interestingly enough, about 65% of the people that we work with, possibly higher, do not have any involvement with police or victim services, and that is their choice. So we may be the only ones who have a good understanding of what their risk looks like. As far as tools, once we've worked with the client for a little period of time, we don't do it out of the gate, but we use the Jacqueline Campbell danger assessment, and that helps us understand the risk of lethality for that client, which means we may or may not put additional safety supports in place and or safety planning. Certainly with every client, safety planning looks different. It's based on the dynamics of their relationship, the type of abuse they experience, the skills they have developed over time. People who experience intimate partner violence have a lot of resilience, and they know a lot about how to manage the cycle of abuse that they're in. So I would say that a good component, once you develop rapport, when that's possible, is to talk that out, because the more you learn about how they manage it, the more opportunity you have as a helping professional to have discussions about how you could increase that for them, and maybe position them to think differently about how they could be safe in a different way. Certainly, you'll also encounter women, and we do all the time, who don't even, on a very basic level, acknowledge their abuse, or that that's what they're experiencing or what that looks like. So that's also a common feature of people who experience intimate partner violence, depending on where they're at in that relationship. It can often take up to 5 times before a person will actually leave a relationship. And we see women, some of Kim's points, we see women who may have had, in their early 20s, a situation, and we're seeing them again in their 30s and again in their 50s. So certainly that clinical piece that might be helpful in disrupting, the cycle of abuse and how people relate to relationships is an important component. It's certainly not one that, Bryony House would provide, but that is a long-term solution to the bigger picture. When I think more about working with clients virtually, I think about the ways in which people providing services can generally use it as a practice to start their service, or now we're dealing with COVID, we're working virtually. So our practice is to talk to everybody about domestic violence or intimate partner violence. And we want you to know that, you can come up with the code word, as Kim talked about. We want you to know that this is, we're happy to get help to you. We say this to everybody, so there's no differentiation between one client or another. It's very true that partners are often monitoring clients, so coming up with ways to figure out that they're not being monitored. If they're on their phone, abusers often have control over the phone and are monitoring what's happening on the phone. There might be ways, if you don't have a code word, to initiate a discussion about, are you all by yourself? Is it an opportunity to talk about that? There might be a way to not engage in those discussions when there might be a risk presented for the client who might be experiencing intimate partner violence. I can say that even women who come into the shelter struggle to talk about their experiences of intimate partner violence. There is the level of shame and internalized trauma around their experiences is pervasive. So it isn't as easy to, and to kind of bring that up when you think there might be something going on, maybe challenging, may actually send them further back into not talking about it, because there are fears about how they feel about themselves, the level of shame they're experiencing. There's a lot of fear over the experiences their children might have witnessed, what child protection might do or say. What's my therapist going to do now if I tell them the truth about what this looks like? So I think those things are very important considerations in having those discussions with clients. And also, if everyone was aware that they can call our distress line as part of your process, it might be another way to offer them a different avenue when it's safe for them to connect to us. Certainly, COVID has presented its series of challenges for Bryony House and our service delivery. At the height of it, we were working out of 4 locations, just to ensure distancing for families. Most specifically, there was really no way to navigate families because children are who they are, which was challenging for us to ensure that we could meet clients' needs in so many different locations. There's a lot of discussion about increased numbers of intimate partner violence. Certainly, we experienced increased calls even from people who we already had a relationship with, experiences around escalating intimate partner violence. You know, my partner's lost their job, things are a lot more stressful now, you know, my partner's home more, all of those kinds of things. So trying to find new ways to discuss with women about how to safety plan in the time of COVID was really, really important. Additionally, we actually knew that we weren't hearing from a lot of new people. And our concern around that was initially, you know, people are more isolated. They're more at risk. They have more concerns about, you know, leaving a relationship because COVID's happening. And as much as we're trying to follow public health responsibilities, those same responsibilities place women at increased risk. So that's why we developed a new portal on our website that actually allowed for women to just text us, and we monitored the text program. And they could actually securely just give us an email and let us know that they needed us to get help to them, whether it was police or there was another way that we could connect with them, even through a family member. And we actually, once we launched that, we actually started to hear from more people, and people we heard from the first time. So it was a significant success. So we've actually been successful in gaining a grant. So we're actually looking at an app program to actually increase women's safety throughout Nova Scotia. So we're pretty excited. That likely will be launched in the new year. Other considerations, I think, when working with clients virtually is safety planning is different and it's unique to every individual. I think it's important to set time aside if you know that the person is experiencing intimate partner violence, to check in about safety planning, whether that's in every second session or those kinds of things, because safety planning changes over time. And oftentimes, if there is a disclosure, there's hesitation among clients to continue that discussion. So ensuring that as you go along, this is still a maintaining discussion, that I'm checking in with you, that, you know, is this a time to talk about this? Because a lot of times that shame will show up again and they won't feel that putting that out there again is really a component of care you might provide for them. And we've definitely experienced that with the clients that we work with, both at the shelter and through Outreach. Yeah. So I know that everybody, well, you may or may not be aware of the Canadian Women's Foundation. They initiated the safety, you know, I am not safe and I need you to know I'm not safe if someone does this. So that is an understood visual cue. We also know that it's out there and some partners are aware of that visual cue. So just to be aware of that as well. And then possibly if you were to get that cue, I think you're all well versed in the types of ways in which you could, you know, send police or do any of those sorts of things. But if people also have the contact information for us, we can certainly fast track for anyone those types of processes if that's helpful as well. That's something that we can provide. And through our outreach program, we can also work with clinicians that are working with, based on the consent of the client, to kind of, I guess, be a coordinated approach in trying to help address the concerns. Certainly, we are not offering a clinical component, but the types of supports that we can offer are the group, are the one-on-one talk support, and we're looking in the new year to launch a group. We'll have a bit of an assessment criteria around what that support group might look like, and we'll actually be looking for someone to help, I guess, provide oversight to the group as well, because we don't have clinicians. But that's one of the pieces that we've heard from multiple women, that they'd love to just get together and talk with other women who have experienced similar situations. And while I use the term women a lot, It's important for everybody to know that we serve trans people, we serve non-binary, we serve gender fluid, just so that everybody knows, because I know we don't often use a lot of the more gender neutral language, but that is who we serve. So that's all I have to say. I welcome questions or discussions.
Thank you, Maria. This is so valuable. I'll remind everyone that they can start typing questions into the chat box. You know, as you were talking again, it's just it's so amazing to me to continue to be reminded of just how important it is that we are part of a network of great community partners. And when I hear about how IWK staff can be working with Bryony House and what those partnerships look like, I think are huge, and learning so much from what you're saying. And I think one of the things that you talked about was sort of that people who are in this situation often have resilience and know themselves and know their situations, and how we can pull on that and truly partner with people to build on their strengths, I think is something that's so consistent across the philosophy of our program as well. So I really value that perspective. And you know, as you're talking about needing to make space and room for this and acknowledge the shame that can come with this, and how we can bring that into the room is super, super valuable. Yeah. So I did have a couple of questions coming in, and I think, you know, I'll put this one out to the whole group. And again, I would encourage everyone to continue to enter questions in the chat as well. One here is about kind of recognizing, and people sort of recognizing that we know that safety planning isn't just about safety planning to leave, but what can we do to support families who are looking to safety plan but are still in situations that could be challenging or could be at risk. So I'll put that out to the panel. Maria, I don't know if you want to start, and then we can have others jump in.
We do that all the time. Our outreach program certainly has worked with women over even a 2-month period to safety plan them out. And typically sometimes people will go to shelter, sometimes people won't. So that safety planning piece should focus on having a bit of an understanding of what the intimate partner violence looks like. Is it physical? Is it, you know, those kinds of pieces. The other thing is, who are your supports, or have you lost all your supports as a result of being in, you know, this relationship where there's such a high level of control? One of the things we have is we can give people phones that have, they're smartphones. They have 6 months on them. They're not traceable. They can call anybody. They have data. It's just an extra tool that a woman can have to safety plan and manage where they're at until they're ready to do so. I think it's about asking them, you know, what do you do right now to keep yourself safe? If the plan is, you know, 3 days from now, 24 hours from now, or 2 weeks from now, what do you need to do to keep safe? You know, you don't want him to see you packing up. You don't want the person to find you planning to leave. What are times when you have free to yourself to do those things? Is there at least one friend that you can let know, and they in some way can also be another person that could be notified? Because as a counselor, you're not always going to be with the person. So is there another person in your life that could know about what's happening, and how can they support you in that? Of course, it's the type of person that you're not going to worry about over engagement, because that's always the fear of someone living with intimate partner violence is, can I control the friendship not to go over the top because I'm trying to manage my risk right now? And friends care, right? So it's about setting those boundaries with your friends. So I think ultimately what that piece looks like is figuring out what do they need to do to stay the most safe, and when it's not safe, what are their options?
Thanks. Any other comments from the panelists?
I think that covered it greatly. Awesome.
Julie or Kathy, anything to add into that?
I don't think so.
Great. So I have another one, and this comes more from our child and youth side of the program, sort of thinking again about, you know, I was struck, number one, I think, Kim, when you were mentioning that oftentimes a lot of these relationships or histories of these relationships can start in youth, and also recognizing that many times we have caregivers or family members involved in care who might be in these situations as well. So I'm just wondering kind of what consideration should we be having on the child and youth side of things, thinking about some of our community mental health clinicians and what things should they be thinking about, or how should they be considering this in some of their work?
Well, I think it kind of goes back to, like Maria said too, you've got to, because there is so much shame, and with, I think, youth, not necessarily the shame, but it's just such a foundation of a lot of the relationships now. It's just there. And so for a lot of those youth, they're not recognizing that this is anything that's not normal, right? A lot of times there can be minimizing, even in adult women. You know, I've worked with women where they say, well, no, he's not abusive. He never hits me.
Yeah.
He calls names and, you know, he controls the finances and he does all of that, but no, he never hits me. Right. So it's kind of, it can be the same with youth where they'll say, well, no, he doesn't hit me, but they don't recognize that jealousy is control and what that control kind of means. But again, I think it's, you know, it's that walking that very fine line of recognizing that, being concerned and being worried, but also respecting where they are and trying to work with them where they are and building that rapport so that, you know, hopefully somewhere down the line, you know, they'll recognize that maybe this isn't okay and this isn't normal and this isn't something that they need to put up with. But again, it's a really, it is a delicate line to have to walk whenever you're working with, because you do have to respect where they are. And I think with youth, a lot of times too, they're also limited because if they're witnessing at home, again, they can't just up and leave home either if they're underage, right? So it's how to then even manage that for them in a safe way. I know, you know, DCS wouldn't necessarily assess them as high risk because they're old enough to get themselves out of there, but even letting them know what is it that's available if they do need to get out of the house quick or something like that. So it's again kind of spanning, you know, pulling that broader lens on things. It's not just adult women that are experiencing this, it's adolescents as well.
Thanks for that. I love that.
And I think, if I can just add, I think it's really interesting. We were talking about this in forensics too, that violence is all the different areas that violence can happen in the home. So I see some of these dynamics playing out between youth who are violent and abusive or aggressive with their parents, and how parents coming in will minimize the violence that's happening in their home, not wanting to share that it actually does get to that point that they're fearful of their youth causing harm on them as well.
I think
a lot of good work on that.
To Kim's point, I think it's important also, one of the things that we definitely see, and I think I've seen throughout my career, is the love language that youth have around that attachment piece, that this over engagement, like which we see as control, they see as love. So the more he wants to be around me, the more he wants to take care of me, that's part of what the grooming looks like, depending on what that spectrum of abuse may look like. There's one point I actually missed in communicating with respect to the concerns that people experiencing intimate partner violence have about having to leave work for a period of time, or having work find out, or having colleagues they know become aware of their situation, is also a significant deterrent for them to reach out to others.
Great, thanks. I have another that came in. I'm just going to read here off of this. So this one's for Maria. I'm wondering, and this will probably be our last question if that's okay. I'm wondering how much the risk has increased for women since COVID due to the lack of available beds due to COVID restrictions. Are individuals able to access a safe bed outside of HRM?
So no, there is no client that made contact with us that we didn't provide safe shelter to that needed it. That would never happen. We would always ensure someone had somewhere to go. We are usually full tilt at 24 and often have a wait list. We're trying to move around either at another location in HRM, or we work with our sister shelters when it's appropriate. A lot of times clients have important ties to HRM if they are from HRM. So there might be custody agreements. There could be, the children might have engagements with the IWK. Mom might be working in HRM, so that might not be appropriate. So in cases where we could do a move, then that's how we might manage that. But we would never leave someone without some option that would allow them to get to safety. Certainly, our challenge with COVID is all of this expense associated with needing, when the numbers go up, we have to move people in different locations. But we've received a lot of support, both federally and provincially, to ensure that women are safe. So we're very happy about that.
Thanks for that. So on that note, I very much want to thank the panel so much for your contributions today. I want to remind everyone that the virtual visit guide, thanks very much to the forensics team who have done a lot of work to put some resources in that as well. So that's available. The Women in Abuse Forum is also on the dashboard as well. So there's lots of opportunities to share this, and we encourage people to continue talking about it. So thank you very much for joining us. Thank you so much to our panelists, and have a great rest of your day.
Thank you.
Thank you.
Thanks.
Bye-bye.
The attendees logging out.